Welcome to another EduMed video in the series on the ITU ward round, and in this one we'll be talking about O, which stands for Other in the ABCD approach to a ward round. This really covers three things. One is discussions with the specialist team. The second is to revisit all the diagnoses that a patient has to make sure that they're correct and don't need updating. And the final thing is addressing nurses' concerns. And within nurses' concerns, we think about the whole multidisciplinary team. So when talking to specialist teams, it's worth touching base with them at least every few days. Most people would like to be touched base with every single day. And what you want to do is to update them of the state of the patient. But most importantly, from your perspective, clarify their plans. Do they have any plans for the patient to go back to theatre, for example? Do they want any further imaging to help with prognostication and so on? It's always worth trying to organise multidisciplinary team meetings and try to coordinate it with communication with the patient's family, especially their next of kin. It's worth trying to have a united, coordinated front when discussing things with the family so that they're not getting different information from different people. Always ask yourself whether the diagnoses that you've got are the correct diagnoses, whether there's something else that could be going on. And a common one is if you assume that an infection is bacterial, it's always worth asking yourself, could this actually be a viral infection? Could this be a fungal infection? Or could this be a mimic to infections such as a thrombus? And then, what is the most effective treatment? You may be on a broad spectrum antibiotic, but your cultures have come back. It's worth narrowing down your antibiotic to that which covers the bacteria that you've grown, if that's appropriate for the patient, and do that in conjunction with the ITU consultant and with the microbiology team. But always question it. There is often multiple diagnoses in these patients. Those diagnoses don't always become apparent until later in a patient's intensive care stay. Probably the best advocate for the patient and your best set of eyes and ears is the nurse. So always ask them whether they have any concerns. Always make sure you've addressed them with every ward round that you do. They often pick up on important aspects that you might miss. Things such as contractures, which they pick up when the patient's being moved, or if they need some better bowel management, if they've got diarrhea, constipation, whether if they're getting lots of diarrhea, whether it's worth putting in bowel management systems. And they're fantastic for trying to show you whether the patient has sleep-wake derangement. And if they do, then it's worth trying to get them to optimize that through non-pharmacological methods and, from your perspective, considering pharmacological methods. So in summary, things are often missed, and these are the things that we need to think about. The nurses are an invaluable resource, and you should try and use them at every option because they are such great advocates for your patients, and they sit with the patient day in, day out, so they have a much better idea of the nuances that you might otherwise miss. And the final thing is actually true of anything in medicine, which is always question your diagnosis. Always assume you're wrong and prove to yourself that the diagnosis that you've come up with and the treatment plan that you've got is the right one for the things that you're seeing in front of you.